If I think about where a lot of our 2016, 17, and probably 18 focus will be, it will be starting to address minimizing the use of narcotics in orthopedic surgery. And this is a little bit more of a sobering, somber talk, and I think just to get some perspective on this issue, in 2014, so this is recent data, we had more deaths from drug overdose than any year on record in the history of the United States. 78 Americans are dying every day from this, 500,000 since the year 2000. To put it into perspective, again, 29,000 people died in motor vehicle accidents in 2014. Double that number died from overdose in 2014. So we have nothing short of an epidemic, and as healthcare providers, each one of us, it is incumbent upon us to try and help solve this problem. I think up until about 6 or 8 months ago, I kind of looked at this from a very 30,000-foot perspective, and I said, I am not that doctor, and we are not that team of healthcare providers that will just give you narcotic pain medication. We see them in the newspaper, people being arrested, people writing narcotic prescriptions, people selling them. We're not that way at all. In fact, really judiciously, really appropriately prescribe narcotic pills for when they are medically required. We do surgery. This is serious business. And then I thought, gosh, well, I don't know who's responsible for this, but for sure, it's not me. And then I started to learn a little more. As it turns out, if we look at the average patient, a third of the narcotic pills we prescribe for someone appropriately prescribed for a surgery go unused. Well, we don't want to leave a patient on a Friday night or a Saturday night in the lurch at 11 o'clock trying to find a pharmacy that's open to address their post-surgical pain. I mean, that would be substandard of care. But at the same time, 1/3 of these pills that we'll appropriately prescribe will go unused. And they'll go in your medicine cabinet. Or they'll go to a friend who on a Saturday night's having terrible back pain or hurt themselves. Or they'll get found when a teenager has a party. And this is this concept of diversion of medications. And this is the second sobering concept. The majority of illegal narcotic prescription drugs come from diverted medications. So it's not that they're getting them from some special source or someone's making them. There are medications that are somehow being appropriately prescribed, getting left over, and getting diverted. So I think that was an epiphany for me, or maybe that's the wrong word because there's something good about epiphanies. That was a stark realization that, holy cow, I may be part of this problem. And that's when I decided, look, I better figure out how to do a better job on this. Now look, I'm in a dilemma, in a bind, because surgery hurts. In fact, routinely, my patients will come in and say, it's not the surgery, especially shoulder, that I'm worried about. Everyone talks about how hard this recovery is. And now we're in a battle because, I've got this polypharmacy of medications, and we need to give our patients enough medication to adequately care for them after surgery. And if we don't, we're going to fail in a world of patient-driven outcomes. We're going to fail our surveys. They're going to say, look, you didn't treat me adequately. You didn't give me enough medication. And we all know that pain must be treated adequately. However, I think we've got to change the way we think about pain a little bit. And this idea of pain is the fifth vital sign, I'd submit to you that blood pressure, heart rate, respiratory rate, temperature, those are your vital signs. While pain is important, it is not a vital sign. And in 1996, this concept came out and it became a very, very dangerous paradigm. And this pain score, this VAS pain score, is what each of us rely on. You can't get out of the recovery room unless you have a certain pain number. You can't be discharged from the hospital. You're going to get narcotics automatically if you have a certain VAS pain score. But look at this. You go from 4, which is uncomfortable, to just a little higher. 6 is dreadful. I mean, there's no chance that we're not going to over-medicate patients with a VAS of 4, 5, or 6. I think you have to be below 3 in certain areas to get out. So we are really setting ourselves up for trouble and for over-medication. And now, again, we've got to we've got this pickle, this battle. We've got this medical metric of value where we have to think about the outcome, the patient outcome, and we have to think about the cost that we're driving that in. So what are we doing here at the Foundation, ONS, and Greenwich Hospital? Well, I think we're swimming upstream because this is a hard problem to figure out. And the first thing we're doing is we're looking at optimizing the value, because if we make the numerator higher, our outcome can be better. So we're looking at better outcomes. We're looking and we're actively creating better patient experiences. And each of you get to see the letters that our patients write in. We want these people to have less pain, whether that's better soft tissue handling, better surgical technique, or some ideas that I'm going to get into. We want to go to fewer, if not no, narcotics. Can you imagine that? Shoulder replacement, no narcotics? That would be really neat. We want to change our prescribing habits. I don't want to have diverted medications. Okay, I think that every one of us in this room has to address this narcotic epidemic. And if we can limit the diverted narcotic, the ones where we write too many pain pills, or we can limit the exposure to narcotic-naive patients, because now we realize, look, we take care of a lot of teenagers, a lot of college-level kids who've never had this medication. Wouldn't it be better to keep it that way for longer? So we want to decrease the cost. We want to shorten the hospitalization. We want shorter recovery room time, because the recovery room is another expensive component of care. We want fewer medications. And look, I'm coming back to it. I stole my own thunder. Can we do outpatient joint replacement? Is it possible? Can we do it in 2016? Maybe it's going to be 2017, but it'll be here. How do we do this? Well, step one starts in the office. And in that 15 minutes where I have to talk to you about your problem, your surgery, your outcome, your expectations, I also have to have an open, candid, and documented conversation. I have to set expectations with you for pain. Surgery will hurt. I have to set limits right away. We have to set limits on narcotic duration. I will only give you medications for a certain amount of time, after which we're going to have to stop. And then you have to identify your outliers, because not everyone's going to fall within this. People who are using narcotics before surgery, and it's amazing to me that it gets to the point where people are on daily narcotic to manage their pain. Gosh, I wish I could get them in the office faster, because we know across the board, whether it's hand, elbow, wrist, hip, or knee, if you're on narcotics before your surgery, you won't do as well, period. If you have depression, you're going to have a harder time recovering. So we've got to identify our outliers. Thank God for, I'm looking right at him now, for Mark Krastowski and his team. We really approach this in a very comprehensive way of multimodal anesthesia. And this is basically, look, we're going to try and understand and address the pain from every level that it starts, whether it's your brain, your skin, your spinal cord. At each level, we're trying to blunt or minimize that pain. And we do that through, again, some polypharmacy of medications, but administered safely and intelligently in a way to make this a better experience. What's new and exciting for me, at least, is this slow-release Novocaine, right? It's not really Novocaine, it's Bupicaine, and it's long-lasting. So a traditional nerve block will last anywhere from 8 to 12 hours. Maybe we'll get a couple extra hours depending upon the person's individual metabolism, but there's a variation. And then what happens is it wears off, and it's a holy cow, really bad couple of hours. Each one of you has spoken to patients, seen them, talked to them. When did your nerve block wear off? At 1:06, I remember it exactly, and it was terrible. So if we can utilize a medication that instead of lasting 8 or 10 hours can last 36 hours, I mean, how amazing that. It's there, it exists. It's these liposomes, sort of like a little bit of these bubbles, and the liposomes slowly release and break off. And as they break off, one at a time, you can have a deposit of medication there for a few days. And it can be a substantial difference. So how are we doing this? Well, hopefully my videos will run here. Well, in the shoulder, we're putting it into the deep layers. It's got to be really methodical. We're getting into the capsule in the back. We're getting into the intermediate layers, getting into each of the tendons of the rotator cuff. Then we come out at a more superficial layer and really get it into the deltoid and the pectoralis minor and the skin. We're using about 100 cc's of material. And this, again, takes a collaboration between the OR staff, the pharmacy, and the surgeon to remember to do it right, to use the right needles. And we compare this to what we were doing before. We were using nerve catheters. And the catheters, they worked well, right? But it's an invasive procedure where a device has to go in your neck. The device stays in your neck. You'll often stay in the hospital 2 days if you're not really comfortable pulling a catheter out of your neck after you had surgery on that same side. So again, you can sort of see how it's difficult. And catheters can be expensive. So what we did is we decided to be really responsible. And we stepped back and looked at what we were doing. And we compared the catheters, which we thought were very, very good, to using this long-lasting Novocaine, Bupicaine, to the catheter. And we just looked at 20 patients. Length of stay in the hospital was a little shorter with the injectable. Total amount of morphine used with the injectable, less. Total morphine per day, less. Already exciting early preliminary data that was still on our learning curve. So let's talk to some patients about this.
I did a 4-mile hike yesterday, and I have been doing upper body on my left side weights and lower body weights.
How many days did you stay in the hospital?
None.
And how many pain pills did you require after surgery?
You know, I don't think I really required any after surgery. I took two pain pills, because you had told me that, you know, to get ahead of it in case there is pain. So I took the pain pills also to help me get to sleep. But that was it, and really don't even know if I needed them, to tell you the truth.
Thank you so much.
You're welcome.
So he's telling us two things. One, how many days in the hospital? 0. He went home same day as joint replacement. The next thing he told me is he took 2 pain pills. Why? Because I told him to, because I was scared that this may not work. So can we go narcotic free? Maybe. Can we do it outpatient? Well, we did with him. So where else do we expand this to, right? Because what else can we do? Well, rotator cuff surgery is extremely painful, and as we listen to our patients talk about how they experience this, they don't get catheters typically. This is outpatient surgery. They're going to go home and they're going to get a wonderful block in multimodal anesthesia, and routinely they're going to have the next day as being a really, really rough day for them. So again, in this methodical way of injecting all the different layers of their tissue, we try and address the pain and think about where the pain fibers are coming from. And how do we do it? Well, here you go. You can see the medication getting put in. And it's a lot of small pokes. Unlike normal local anesthesia, which will spread in the tissue where we put it, these little liposomes will only stay where you put them. So you have to put them in a lot of places. This is why we have to use a lot of volume. And putting 100 cc's into a shoulder could make you step back and say, gosh, am I doing this the right thing? Am I going to make them too swollen afterwards? Well, it ends up being pretty easy, pretty routine, and not that big of a deal. And we haven't seen any complication or untoward effect of it. But the question is, can it work? And can it work as well in shoulders? We're trying to study that. We sat in front of the Greenwich Hospital IRB with a research proposal. And we're going to come back and we're going to look prospectively at patients who get this and patients who don't to come up with some really hard data to see if it's a good idea. But let's see anecdotally if it was a good idea.
Good morning.
You had rotator cuff surgery yesterday.
I did.
Did you notice a big surge of pain when your block wore off?
No.
So it's a pretty smooth ride?
Very smooth.
And are you pretty tough with pain?
No.
Yeah, thank you. So this is a woman who came in from Florida to have, so she, unlike most patients, she stayed in the hospital for rotator cuff surgery. She was very, very nervous about the pain. And she really, we sat down, she wanted to meet with the anesthesia team before, and there you go. I mean, she didn't have the pain. So, anecdotes are great, so I decided to ask a couple more people. Hi there.
Hi, how are you?
Good. Tell me about what you had done.
I had a bone spur shaved down and a bicep repair.
How much did it hurt?
I had no pain whatsoever. I took a pain pill the night of my surgery because they really scared me at the surgical center to tell me to get ahead of the pain. But after that, I never took any pain pills at all. I just took some Tylenol.
Did you feel like you needed that pain pill?
Absolutely not.
Thanks.
So here are the paradigms that these patients are asking us to change. One, we're telling them to take the pain pills. Why? Because this is new. Why? Because we still don't fully believe it, all the time. And why? Because it doesn't work 100% of the time. But clearly, and I'm not randomly selecting, clearly we're coming up with closer answers. So, it's not all rosy. I think that there's some earlier data that's negative or it doesn't help. So it's not that this long-lasting Novocaine is perfect. Some of the earlier data suggests that it doesn't help as much or it's not as effective or you can use regular local anesthesia. When penicillin was first discovered, I don't think you went to the agar plate and just took a slice of it and got rid of the plague. So there's a lot of learning and growing. Same with blood pressure medications. A lot of patients had to spend time going through trials for us to figure out how to use this. So the expansion and the application and the wrong cocktail, or we didn't use appropriate multimodal. I don't know that it's only one thing that we're doing. It is a body of work over 12 or 15 years where we're slowly looking at each different way in a multimodal way to try and minimize the pain that they're having. So what do we need? What do we need to get better acceptance, and how do we go forward? Well, you know what? As healthcare providers, we want hard, solid, peer-reviewed data, and I agree with that. So we need to publish our current techniques so we can make it reproducible and reliable. Well, that's underway. We need to better describe the neuroanatomy of the different joints that we're trying to cover, right? So we need to understand this, because if I and the other doctors can understand the neuroanatomy, we can address the pain generators even more effectively. We need more regional expert meetings where we can align anesthesia and surgeon. And again, in our world here, it's a very fortunate alliance. It's a team. I don't know that it's that way everywhere else. Patients, and you guys, this should be grassroots. People should come in and say, listen, I want that medication. I want you to do it in me. Well, you know what? There's a problem here. It costs more money. And I had to sit in front of the pharmacy board and make a plea for them to allow me to use this. Well, it only costs $300, right? So if we look at the $300 relative to the $26,000, which is probably the total cost of a shoulder replacement, you're talking like 1%. 2% for a rotator cuff repair. But I would strongly submit to you that $300 to avoid one narcotic addiction, or $300 to avoid one narcotic death, I mean, that is nothing. So when I face people telling me about cost reduction, I really think that they're missing the boat, and they're not taking their role in addressing this epidemic. So we have a triple aim here, and this triple aim is better outcomes, fewer complications, a better patient experience. I want less pain, I want enhanced value, I want to turn the tide and see that we can change prescribing habits and maybe eliminate narcotics from certain surgeries. And you need a committed team. You need your team from anesthesia, you need your team in the pharmacy, and you need your OR staff to all be on board with you, to have it, to make it ready, to do it right. So look, don't believe me, let's go with her.
Hi.
Can you please describe how much pain you had after shoulder replacement?
It was amazing. I had none. I actually took no pills whatsoever. It was perfect.
Can you please raise your arm up for me?
Absolutely. No problem.
Thank you.
You're welcome.
So that's it for this talk. Thank you.